Welcome to Joint Ventures, a sports medicine podcast from Smith+Nephew. My name is Christopher Klifto, and joining us today is Jacob Calcei, a sports medicine surgeon at University Hospitals in Cleveland, Ohio, and Stephen Mora, a sports medicine surgeon at the Restore Orthopedics in Orange County, California. This episode will focus on considerations for the athletic shoulder, how we can leverage patients on our own biology to get them back to play. So, Jacob, what is the typical patient that you see in your practice?
So I see a lot of athletes, take care of a lot of overhead athletes, throwers, volleyball players, CrossFitters. And so you see a lot of these overhead overuse injuries mixed in with kind of the acute stuff. Now the acute stuff, is very different handling it than like the overuse chronic injury. And the overuse chronic stuff, a lot of the times you want to try to rehab them. Overhead injuries oftentimes do best, like your slap tears, your rotator cuff tendinosis, do better with some rehab and time and maybe sort of that non-operative route until you kind of fail that. Now, the acute injury is a different beast. I take care of a lot of baseball players, football players, and so they really present very differently, even within one sport, depending on your position, what you're doing. Your design, like the things you have to get back to are very different.
How much do you love taking care of CrossFitters?
CrossFitters are very challenging. They don't stop. They don't want to stop. They love what they do. They love lifting heavy weights overhead. And so you got to really try to get them back to that. And if you hold them back and don't let them do it, they will not be happy.
I'm asking for a friend. How do you get a CrossFitter to actually follow the rehab protocol?
You can get their coaches involved. So one of our reps actually in the OR is a CrossFit coach. And so I use him as a resource when I'm getting some of these CrossFit athletes back. I'll have them pop over to his gym, or really it's their community that wants to sort of pull them in and give them a big hug and sort of help them along in their rehab process. My big thing, like any athlete, is I can get you hopefully back to where you were and maybe a little better if we follow the process, do the rehab, take the appropriate time and rest. And so that's kind of the goal, and that's what they want to get back to anyway.
Yeah, I have to talk to your coach because I can't get a CrossFitter ever listen to anything I tell them. Dr. Mora, what about your population?
I have a mixed population, but in terms of the athletes are combat sports athletes, and I'm in an area that actually has a lot of that type of activity, combat sports. So I see a lot of those athletes, and it's usually related to instability, joint instability conditions, either the recurrent instability or the first-time instability, first-time dislocators. That's my athletic population, and then the other component in terms of the people that I see are work comp patients, especially police officers. I see a lot of police officers and firefighters, and the reason is I think that they gravitate towards me is because I take care of mixed martial artists. So I have a large population of police officers and firefighters because they've just heard that if I can take care of the combat athlete, I can take care of them because they actually suffer very similar injuries.
How did you build a combat athlete population, and what's it like rehabbing them and treating them?
How do you build it? Well, you build it by gaining their trust first. You build it by gaining their trust and succeeding in taking care of a few who then will tell others that you did a good job. And the way you gain their trust is you have to understand their culture, first of all. You have to understand that they have a different culture in the same way that police officers have their own culture, and it's based on trust. Myself, I was doing boxing. I like to box, and I was training at a boxing gym that also had MMA fighters that came in. This was many years ago, 15 years ago. So they got to know me because I was open to talking to them about their craft and learning from them. And they learned that I was an orthopedic surgeon. So I had one or two come in, and then it just blossomed after that because they learned that I can take care of their types of injuries, and I understood their priorities. Their priorities include being able to start a camp safely and effectively, and being able to get through the fight as close to 100%, especially if they're injured, as close to 100% as possible, and understanding that it's necessary for them. These athletes do not have multi-year contracts like NFL or Major League Baseball. These fighters have 3 to 5 fight contracts. So if they don't fight, they don't get paid. That's how it works. So you have to understand that first. So if you understand what their needs are, then they will learn to trust you, and they'll learn to come and see you.
I would like to ask you both this question, but like, what's the difference between taking care of combat sport athletes, your professional sport athletes, and the general population? What's the psychology behind getting them back to the game? Because that's ultimately what they want to get back to.
Well, there's a psychological component when you're dealing with high-level athletes. They have to feel confident that they'll be able to perform at the level that they need to perform to be able to win. So there's a psychological component. When you're dealing with workers' compensation patients, they have more time to heal because they can be off work and they can be and they receive some compensation during that time period, whereas these fighters actually don't. So you treat them a little bit differently because they don't have the same amount of time to rest compared to other people other athletes. Like your CrossFitters, they got time to rest. I mean, some of them are not getting paid per CrossFit event. Mm-hmm. It's not their profession. So these folks don't have a lot of time to rest.
And Jacob, I know you talk a lot about the intrinsic factors of shoulder pathology. Mm-hmm. You see that in a lot of your patients, correct? Can you just comment a little bit about what that looks like and how you get them back to the game?
Yeah. I mean, first of all, I think your point on the workers' comp patient, especially the firefighters, the police officers, they're athletes, and that's how I talk to them like they're athletes, and I sort of tell them that their return to sport protocol is going to be very similar because they got to do the same kind of stuff that an athlete does when they get back to work. And so, anyways, I think that's a really good point. I think something that should be taken out of this is when you're talking to a patient, whether they're a steel worker or a police officer or a high-level athlete, a lot of the movements that they have to do, things they have to do, the impact, the amount of like endurance that they have to have in their joint is very similar. But a lot of what we think in the especially the thrower shoulder, you get a lot of this internal impingement. That's kind of the chronic thing that you see. Any overhead athlete, you can see it. I see it a lot in like the water polo, volleyball, baseball pitchers. They get this essentially as they're getting into their what they've been doing for years is they've been peeling back their rotator cuff to give themselves more motion. So they get into sort of these hyper ranges of motion in order to get bigger whip on their arm and increase the speed, right? Yeah. So that's how they adapt. And if you fix that, right, like a normal patient, if they had an acute injury and you put it right back, they've been peeling that off for years, right? Giving themselves that extra space that they need. If you put that back where it belongs on the footprint, right, if you try to repair them, they'll be very unhappy because you're going to tighten them back up. They're going to lose some of that motion. They're going to get pain at end range of motion.
So what do you do?
So I mean, I think one, rehab them. I think that's a big thing is you try to not just treat the pathology a lot of the times. You see an MRI and you're like, this is easy fix. We could go in there and put it back together. But that may be not what they need. You got to really examine them, put your hands on them, spend some time with them, talking to them. I'll even sometimes have our primary care docs, sort of maybe selectively inject a spot and have them go throw and see if that actually helps their pain. And so depending on the resources that you have where you are, really try to get them into their space and get them to do the things that they need to do. Because it's hard to examine a thrower in the office. They got to do so much in terms of the speed, the velocity, the time. And so just a quick exam in the office doesn't really get you there. But I think there's a lot of options, in terms of non-operative stuff. And then you can get into the biologics world where you think about maybe an injection, right? If they're in the off season, they have a little bit of time off, they can rehab it. But going back to your question before about, how do you talk to get them back and the timing, depends on where they are in their contract, depends on where they are in their career, things that they want to get back to. And so I just think it's really, really important, and James Andrews talks about this all the time, is you have to really treat the athlete and talk to them about what their goals are, where they are, what they want to do, and then really spend some time with them trying to figure out what their true pathology is and what's causing their issue.
You bring a really good point up, right? So like there's a combination between non-operative treatment and biologics. I'd love to hear from both of you, maybe Dr. Mora first. What's your take on BMAC, PRP from the non-operative perspective for shoulder injuries in athletes?
It's sometimes it's a hard sell because it tends to not be covered by insurance. So that means that there will be money out of pocket. So it's an investment for these folks. And if it doesn't work, which in some cases it won't, just like any other therapy, it's it's hard for them to just swallow that and say, it didn't work. I just spent $5,000 or $10,000 for BMAC, let's just say. It's important that we choose, or that I choose the case carefully and choose patients that are more likely going to respond, because it is an investment on their part. So who do I choose? Intratendinous tears, intratendinous rotator cuff tears. They have shown to do well with injections of either high concentration PRP, leukocyte poor PRP, or BMAC. BMAC is a big jump in terms of cost, so I tend to focus on high concentration platelet-rich plasma, 60 cc blood draw, leukocyte poor, ultrasound guided. I also use these biologics for degenerative joint disease of the glenohumeral joint. So these folks usually have degenerative labral tears, but it's actually a multi-pronged approach, because the injection is not the panacea. It's actually mobilizing the joint, getting the shoulder to move, getting some strengthening back, especially the range of motion. You got to get them to stretch. You got to take the pressure off that joint. And then I inject some platelet-rich plasma in the same way that I would an arthritic knee. So those are the main two applications that I use, regenerative medicine, as well as biceps tendinopathy. Those are cases where usually you can hit a home run with a PRP injection in the right approach.
And what about you, Jacob?
Yeah, I mean, I agree. I always tell patients that it isn't going to hurt you; it might hurt your wallet. And so some of these things are very expensive and prohibitive to patients. And unfortunately, some of the insurance companies are lag behind. What sort of we know about it, and that there is some good success with these. But the really important part, and the point that you made, that they have to rehab it. They have to rehab it like it's a surgery, right? And so you can't just do the injection and then go out and play. You actually have to rehab it, address all the other physiologic changes that maybe are happening, try to get their scapula moving right, get better control of their whole shoulder girdle, and really try to get them back to that motion that they need. And if you don't do that and you just do the injection, it's not going to make a huge difference.
Yeah, 100%.
And there's some buy-in when they have to pay up front for cost, right? I feel like patients are like, hey, I spent X number of dollars. I'm going to really work on my rehab. Workers' compensation, totally different patient population. I have not solved this at all. Dr. Mora, you say you work with them a lot.
Yes, I do implement biologics for these patients because they feel that they're being treated like professional athletes, which in my practice, almost everybody gets treated like a professional athlete. I mean, why not? If the therapy is going to make a difference, I don't discriminate unless it's not necessary. So yes, I do use PRP. Workers' compensation sometimes covers platelet-rich plasma, especially if you provide peer-reviewed information. And there's plenty of peer-reviewed information that supports PRP for degenerative conditions as well as soft tissue. So I use that. That gives them confidence that I'm looking out for them. They need to have, just like the fighters, they need to have the confidence that you are not a workers' compensation doctor. You are treating them as their doctor, and you're doing everything possible to use the right wording and the right evidence to get them the treatment that they need. And hopefully they usually reach a point that they have to go back to work. I mean, sometimes, especially people that have good retirement plans. They really do, actually. Harder, the ones that don't have great retirement plans, they are a little bit difficult to get to work. But you just make sure that you go through in your mind that you've made the right diagnosis and you've gone through the right treatment algorithm for that condition. If they're not getting better, you have to ask yourself why. So if it's psychological, or maybe you missed the mark as a physician and you didn't diagnose it right. That happens all the time, right? You could have a root tear that you missed or somebody else missed. Or a shoulder problem that somebody missed, So then I revisit the diagnosis, make sure that I nailed it. And if I feel that I did, then at that point I start to coach the patient or massage the situation, tell them, it's time to go back to work after you've done everything that you normally would with anybody else.
Jacob, you're in a blue-collar town in Cleveland. Mm-hmm. People want to work, right? Or no? Yeah. Do you have the same issues that we have?
I think it's a mix. You'll always get some of those that don't want to get back to work. And really, for me, a lot of it is you don't want to give them any reason to say that they can't get back, and so you want to try to get them moving early and rehab them early. So, for example, say you have somebody who has an acute injury to their shoulder, and now they have a partial thickness rotator cuff tear. Right? They know that. They see the MRI read. They go through the process. They fail the non-operative stuff. A takedown and a repair for them is a long process. It has a lot of pain involved. They're going to get stiff. They're going to have a lot of reasons for that to drag out. And so an option where, say, with a REGENETEN implant, you can put a bioinductive collagen implant on top. You can get them moving within a week to 2 weeks and really give them an opportunity to enhance their biology, get their motion back, right, improve their mechanics overall, and not really give them an excuse to slow down. And so for me, that's why it's a nice option in that setting. Similar to, we were talking about the internal impingement, the overhead throwers. So you don't want to put that rotator cuff back on the footprint. You don't want to give them that internal impingement again, but they have cuff pain. They failed the non-operative stuff. All their motion's better. You did a good job of rehabbing them, but they just really can't get back to where they want to be because of pain. That's where the REGENETEN implant also works really well because it's on the bursal side of the cuff. You're not messing with that articular side, which they need to have peeled back in order to get their motion. But you give them an ability to thicken their tendon, heal it, decrease the amount of tendinosis and inflammation going on, and you get them moving sooner. So it gets them more involved in their rehab process. So for me, it's a lot easier of a discussion when you're like, hey, you're only in a sling for a couple of weeks. We're going to get you moving right away. We're going to have you back within this window that's a lot shorter than what they would expect from all their buddies who have had a rotator cuff repair. And so whether it's that workers' compensation patient or an overhead athlete, especially the CrossFitters, you can tell them, hey, I'm going to get you back sooner. We think we can, really address this problem that you have with something that allows us to get you out of a sling sooner, get you moving sooner. They're happy, right? And they feel like they're involved in their rehab. The patient, when you have a big rotator cuff, you sit them in a sling for 6 weeks, they kind of get bored. They feel like they're stuck. They feel like they're not doing anything. So you want to bring them into their own rehab process.
You bring up a really good point. I'd like to ask you both this question. Maybe we'll start with you, Dr. Mora. But the athletic population is very different with REGENETEN. When you treat these patients, specifically for partial thickness rotator cuff tears, what's the difference in your treatment algorithm and specifically your rehabilitation?
Well, I think that athletes place a lot of pressure on their joints, especially collision athletes, CrossFitters who train like crazy. So it's important to recognize that and think about how you're going to do the repair so that it's as bulletproof as possible. So no matter how hard they abuse it or how non-compliant they are, you're going to get a better result or improve the outcome. So for other than the partial thickness rotator cuff tears, which I will use REGENETEN. I mean, that's almost an automatic because they do so well, and it's been proven that the tissue is great and the thickness of the cuff is really nice. I've applied REGENETEN in numerous athletes because I know that it's going to decrease the re-rupture rate, number one. Number two is the tissue that's formed is better than if it's just a rotator cuff repair by itself. They've done biopsies on what it looks like. It's amazing that they form tissue that is actually better than or more natural, actually, that can sustain more, or that has good tensile strength, like a natural tendon, right?
Absolutely. Yep.
So if I would want it in my shoulder, why wouldn't I want it in anyone else's shoulder, especially someone that works and does a lot of overhead, not just overhead throwers, but construction workers that have to put their arm up to drill. Or anyone that has that type of work responsibility, but even for the average young person with a 40 or 40-something-year-old with a rotator cuff tear, I think it's important to give them the best chance. So they only have to go to bat once. I remember hearing a well-known physician talk about that. People don't want to go to bat twice. It's just one time, hit a home run and be done with it. And I think that REGENETEN implant, the bioinductive collagen implant, does that for these patients. So
yeah, I mean, you didn't have a solution for these overhead people, right? So you didn't have it. You either took them down and repaired them, or you debrided it and just hoped that they somehow felt better, right? Just by you going into the shoulder joint. And so I think you could almost say that the aggressive approach would be to just debride it and leave and hope they get better, right? And so the more conservative thing, sometimes, to me at least, is to do something active and put an implant in there that'll help them, heal their cuff, improve their, the pain and dysfunction that they're having, but not slow them down. And I've used it in pretty young patients, into their 20s, especially in their 20s, yeah, especially in an overhead thrower. And again, you got to go back to did they do all the pre-rehab right? Did they try to get all their motion back? Did they go through the steps and fail them from a non-operative standpoint to where they actually needed to have something done? Because I think in general, you kind of want to stay away from throwers in the operating room if you can, right? Or overhead athletes. But when they don't do well and you need something, I think it's a really good option.
Yeah.
So is your protocol change for either one of you, for your athletes? Is the same with like the partial or expedited recovery, maybe 2 weeks in a sling? Does the athlete change when using regeneton patch or no? Same protocol?
For me, it's the same protocol.
Yeah. So for me, it's the same. So if I'm going to use a REGENETEN and I'm going to get them moving, it's really just getting their motion early, getting their scapular, kinetics back, and then eventually kind of getting them up that rotator cuff strengthening pathway. But that pathway is pretty short for me.
With the REGENETEN implant in athletes, have you noticed, either one of you, any sort of stiffness or any issues post-operatively?
Not with the patch in and of itself. Rotator cuff repair inherently will lead to stiffness, and one has to be aware of that. As a physician that does a surgery, you have to be able to act on it relatively quickly. Otherwise, the resistance within the joint, the glenohumeral joint, the forces change, and there's a lot more tension on the rotator cuff repair, and they end up torn. So it's not necessarily a side effect. I've never heard that compared to other types of grafts from many years ago that I used to see that in. So I haven't seen that with REGENETEN, actually.
Yeah, I don't think stiffness is the thing that I see. Some of them will get a little bit of like an inflammatory response around that like 7 to 9 week mark. And I think that's as those staples are sort of dissolving and going away. And so you just kind of coach them on that. You tell them, hey, you're going to have a little bit of, and it's also in that phase where they're kind of getting their strength up. And so they're being more active, and I think it all contributes. But if you warn them, I think it's fine, and you just coach them through it and just say, hey, let's ride through it together. And then usually around that 9-10 week mark, that kind of dissipates and they feel a lot better. But that's kind of where I'm a staple minimalist. I think the implant is what's doing the work. So as long as we can get it on there, get it to situated and stable enough, minimal staples on there is better.
Yeah. What's your construct? How many staples do you
I'm
use?
kind of I'm a 4 staple guy.
Where are they placed?
Kind of the 4 corners usually.
Okay. Well, you are a minimalist. That's
if you can get it under
impressive.
if you can get it under good tension and kind of get it onto good tissue, it stays really nicely. Turn the water off. Get out of the shoulder. And if you do it in an efficient manner to where the implant itself is still in really good structural shape as you're putting those staples in, it looks and feels really good. You're pretty confident that it's in a good spot. And again, I think you want to minimize those staples. And I don't really use too many of the bone staples. I think one of the benefits of the implant itself and the way and the fixation that they have currently with the soft tissue staples is that it all incorporates / goes away, right? So then it's all the patient's normal anatomy. There's no extra stuff in there. Obviously, if you need to use the peak staple on the lateral side, that's totally fine. You just got to make sure you get it down deep enough. But for me, I'm kind of a staple minimalist.
Interesting.
You mentioned earlier that you treat instability a lot with your combat athletes. When you see these patients, do they have more bone loss than normal patients? What's your algorithm for treating them for bone block procedures versus soft tissue procedures when you see a combat athlete or athlete in your practice?
Pretty much all combat athletes, the serious ones, not just the recreational weekend warrior dad that went to the UFC gym, but the real combat athletes, they get a bony procedure. They will get a bony procedure.
Yeah, because they're super high risk, right? They're really challenging.
They're beyond high risk.
Yeah.
They're beyond high risk. And they usually don't come in when they've dislocated once. They'll try to tough it out, and just like many people, they as it goes back in, they think it's fine, and then it dislocates or subluxates 3 to 5 more times, and they end up having bone loss on the glenoid side as well as the humeral head. I have, early on in my career, I've done soft tissue work, remplissage with Bankart repair, tighten things up, but I've had some failures in doing that. And then I've looked at the literature and seen what other people do, not necessarily in combat sports, but in rugby players, football players, or failed primary surgeries. So I do a lateral J procedure, open lateral J procedure is what I like to do.
And that's for even bone loss over 25, 30%. You're still going to think about a lateral J.
Yeah, a combat athlete, a serious combat athlete is going to dislocate their shoulder. In my experience, they're going to dislocate their shoulder, and they're going to come back to you, and they're going to be upset. and it's going to be on the news.
Don't want that. No way.
They're going to show the dislocation in the ring.
Yeah. Your face next to it. Yeah. Been there.
You don't want to do. You don't want that.
But you, Jacob, same thing?
Yeah.
Lateral
same.
for you too?
Yeah, contact athletes, especially, football players, the linebacker, defensive back, those ones that are kind of at higher risk of having recurrent instability, definitely lean towards a bony procedure, even in the absence of significant bone loss.
Yeah, 8% Hill Sacks. You're still going to do lateral.
Yeah, I think in our especially in the mixed martial arts, the wrestlers, those are the ones that are really high risk and very challenging. I'll still think about it pretty early on in a lot of the contact athletes, like the football players. But one thing that I've sort of started to utilize if I need to is if you do have to do an open procedure to the shoulder where you're taking off the subscap instead of just splitting it, you really want to make sure that subscap heals. That's the most important part of the case, probably, is repairing that back on. That's not just an afterthought as you're getting out of there. And that's where I've used REGENETEN before too, because I think you want to do everything that you can to make sure that subscap heals on your way out. And so I think putting that REGENETEN implant on top of that, it gives them the best chance of having a really solid, sort of tendon to bone healing.
Yeah, it's a really interesting indication. I think people are expanding and using REGENETEN for different reasons, including that. And I use it particularly for myself for shoulder arthroplasty. I do a lot of shoulder arthroplasty. If I have a tenuous cuff or a subscap, I use it for the same reasons. How do you apply it? Where do you put it on the subscap? What's your technique?
Yeah, so where a lot of the failures happen are kind of at that tendon muscle interface, right? It's not usually off the tendon doesn't pull off the bone. So you want to make sure you kind of span that. You're not trying to go over the biceps, right? You want to make sure you don't strangulate the biceps as you're putting that on. So you really try to put it from sort of that lateral footprint of the subscap and from there medial.
We talked a little about the biceps now and overhead athletes. I'd love to hear from both of you. Are you in the camp that we should completely abandon slap repairs for athletes, just do all biceps and adhesives, or is there a role for slap repairs still for overhead athletes?
Yeah, it's a tough one. I will do an occasional superior labral repair if the symptoms are in a young patient, like under 20, and if it seems like it's a pure superior labral tear, posterior maybe, no involvement of the biceps and no symptoms involving the biceps at all. It's a hard sell to tell a young patient that I'm going to reattach their biceps for a condition that seemingly doesn't involve the biceps, because the word biceps is not in SLAP. So it's not until they read about it, but then when they read about it, they'll read about something, or they become informed. They'll read that it's used in older people, 40-year-old or whatever it is. So they can question. But if it's a labral, just a superior labral tear, it's a nice repair, I'll do it. But I rarely see that, actually, because I don't really see too many repetitive throwing athletes. I don't really see water polo players or too many baseball players. So maybe Jacob has.
Yeah, you don't want to constrain them, right? So I think a lot of those slap failures that happened over the years, where people had pain and continued issues, where you're putting the anchor in the front of the biceps, you really want to stay away from that. As tempting as it is, and I just had one the other day where I was talking the residents through it, and my PA, I was like, you do not want to put an anchor in the front of the biceps. You can make the repair look perfect, but they are going to hate it, because you really need a little bit of that dynamic motion of the biceps anchor, so that when they get into that abducted, externally rotated position, that the biceps can roll back with them. If you constrain them in the front, they'll hate it. Yeah. And you really don't want to put your posterior anchor past 10 o'clock, probably. And so if you can stay at that 10 o'clock range, and you can sort of bring that slap and the biceps anchor back over, I think in a younger athlete, there's a lot more utility to the biceps than we even realize at this point. I think we're learning more and more that maybe the biceps is an important part of the dynamic motion of the shoulder, especially in overhead athletes. So I think if you can keep it, it helps. But you just got to be really careful with your technique and how you do it. You don't want to over-constrain them.
What is your technique? What type of anchors are you using these days? Is it knotted anchors, knotless?
Yeah, so I use a knotless anchor. There's the new knotless Q-Fix anchor, which is a really easy fix for these. I use the same thing for any of my soft tissue instability, for my remplissage. I sort of use that staple technique. We're using 2 of those anchors. So same thing for the slap. I really don't like knots in the joint. I think it can irritate them a lot, and these anchors are super strong. strong. And so I don't think there's any real utility to going anything, bigger than what they offer.
Same for you. Have you evolved your technique over the years?
Microraptor is what I use.
Yeah.
And that's what I have used historically. I've been recently using the knotless Q-Fix, which is an absolutely great implant. I mean, it's a great implant for this type of repair. Small 1.8 millimeter drill hole, and very nice a technique that compresses the labrum very nicely.
And I think a lot of it too, especially in labor work, it's hard to get the angle you need, And so the inserter or the drill guide is just as important as the actual anchor itself. And so the drill guide is really solid. You can sort of lever around the head and really get a good angle into the glenoid when you're putting it in. And so I think that's a huge bonus to that implant too.
Yeah.
What do you tell patients with return to play with this pathology? Superior labrum tears, right? You tell them they're getting back to sport, or are they getting back to the same level? What do you tell your patients?
Yeah, it's challenging. The goal is to get them back to the same level. My goal is you want to get them back stronger than they were before. It's kind of the conversation that you have with them. But it really involves a lot of buy-in on their end. I usually tell them, I do 40 minutes of work, maybe, and they're going to do months and months of work. So they're like, you did a great job. I'm like, you did a great job because you did all the work, getting yourself back. And you got to have good physical therapists. You have to have a good sort of multidisciplinary team around them, because that's what's going to get them to the finish line. They're going to be the ones that spend all the time with them, getting them there. But you also have to set expectations. It's a long process, especially with overhead throwers. It's a bit challenging. And again, it goes back to that. There's probably some labral pathology. There's probably some cuff pathology. Where is their pain actually coming from? Can you do a good exam and kind of figure that out ahead of time? So I think proper indications also helps that process.
Do you agree?
Yeah, I 100% agree in terms of figuring out what's the problem, what is the culprit. MRIs will always show multiple abnormalities, cuff, labrum. Whenever a patient sees the word labrum on an MRI report, they expect a repair. So it's important to figure out what the pathology is. Sometimes it's just loss of motion. Sometimes it's scapulothoracic abnormalities. Mm-hmm. In terms of returning patients back, I'm dealing with combat athletes. They're not throwers. I think throwers are they're different people. They're very different. They're like a finished carpenter versus a construction rough carpenter. They're very different people. Do you agree? They're very different, right? I mean, they're trying to throw a ball at a certain spot, a certain speed. I'm dealing with guys that want to punch you really hard and knock somebody out. It doesn't require like tons of accuracy unless they're like true boxers or strikers. But so it's a little bit different, and I really don't see that group of patients. But in terms of the recovery or rehabilitation, I think it's important to just keep an eye on them. You have to see them frequently. Not every 2 months, because you may lose an opportunity to educate, and you may lose an opportunity to intervene to get them over a hump.
Well, thank you, Dr. Calcei, Dr. Mora. This was a Joint Ventures podcast on biologics and shoulder athletes. We all learned so much from your insights, and thank you for joining us today.
Thanks for having us.
Thank you.